Hi, my name is Michael Cohen, and I would like to thank the Myrie Syndrome Foundation for the opportunity to present today on ENT problems in Myrie syndrome. I have no relevant financial disclosures other than a sponsored research agreement with Med-El Corporation. So ENT problems are common in Myrie syndrome, and some of the specific problems that I'll discuss in detail today are hearing loss and airway stenosis. I'll start by talking about hearing loss in general and how this occurs. So this is a map of the ear. We see the ear canal here, the external ear, the eardrum at the end of the ear canal, and behind the eardrum is a space called the middle ear. Now, the middle ear is lined with a mucous membrane, just like the lining of your nose, and therefore it produces mucus, which naturally drains through this pathway called the eustachian tube. And when mucus is produced by this middle ear space in a manner that can't successfully drain through the eustachian tube, we get a condition called middle ear fluid or otitis media with effusion. And we'll talk about that a little more. But as sound comes into the ear canal, it bounces off the eardrum, hits these three small bones of hearing called the ossicles, and they have names: the hammer, the anvil, and the stirrup. And those ossicles transmit vibrations from the eardrum into the inner ear, specifically to the cochlea. And the cochlea takes vibrations from the fluid inside its duct, and those vibrations are transmitted into a nerve signal that goes directly to the brain through this nerve called the cochlear nerve. And so when we have hearing loss, it can happen in two main ways. The first is if the hearing is being blocked anyway in this pathway leading up to the cochlea. So if there's a blockage in the ear canal or a problem with the eardrum or fluid in the middle ear, like we discussed, we call that a conductive hearing loss, meaning sound is not being conducted to the inner ear. However, if the problem is due to the inner ear itself or to the nerve of hearing, or even to problems with the brain beyond the nerve of hearing, we call that a sensory neural hearing loss. And these are two very different mechanisms which have a very different treatment modality in many cases. So what does this look like on a hearing test? Many patients with Myrie syndrome will have had a number of hearing tests, and let's talk a little bit about how to interpret that. So on a hearing test, the right ear is represented with circles, and typically they are red if it's a hearing test that's in color. The left ear is in blue and is represented by X's. And this is what a hearing test with normal hearing would look like. So these are the different frequencies that we're testing, moving from low pitched up to high pitched. This is how loud the sound has to be in order for the patient to hear it at each given frequency. So for example, this red circle here means in the right ear at 500 hertz, a low frequency sound, the patient was able to hear it at 10 decibels. Now, normal hearing is anything 20 decibels or better. And so this would be an example of a completely normal hearing test. Mild hearing loss would fall into this range: moderate, moderately severe, severe, and profound. And so let's look at some more hearing tests that aren't normal. So this would be a hearing test that falls primarily into the moderately severe to severe range, although in the low frequencies, there are some normal responses. And so sometimes hearing is not the same at every specific frequency, and this can affect how people understand sound or spoken language at those various frequencies. Now, this is an example of a conductive hearing loss. How do we know? Because the responses down here are in the moderate hearing loss range, but these brackets, which you might see on a hearing test, are a result of bone conduction testing. Bone conduction testing happens when we put a device behind the ear that vibrates and bypasses that whole middle ear system. It sends vibrations directly to the cochlea. And in this case, the bone conduction testing is within that normal range, telling us that this is a conductive hearing loss. And there are actually some hearing devices that utilize this strategy of sending vibrations around the middle ear and directly to the cochlea, called bone conduction hearing devices. Now, here's a sensory neural hearing loss. We see that the air conduction thresholds are down here in the moderate to moderately severe range, and these little brackets are lining up with those air conduction thresholds, meaning it doesn't matter whether the sound is going through the ear canal or vibrations are being sent directly to the cochlea. We hear it at the same level either way. So that tells us that the problem is in the inner ear. Now, this is a child with Myrie syndrome. In this case, we see the bone conduction, which is these little symbols here is in the normal range, but the air conduction is in the mild bordering on moderate hearing loss range. So this would be a conductive hearing loss in a child with Myrie syndrome. So what are some common causes of conductive hearing loss? Well, most common would be fluid behind the eardrum. This is an example of a normal eardrum. We can see those little bones here behind the eardrum. And this is an eardrum that has fluid. We can see there's some bubbles. These are strands of fluid, and this is all fluid in this area that's sort of blocking our view of those little bones behind the eardrum. This will be fluid that's not infected. Sometimes we have fluid that is infected, and this is an example of an ear infection. So we see just white stuff behind the eardrum. This is pus. It's very inflamed. The eardrum is bulging. That's an example of acute otitis media or middle ear infection. Now here's a little video, and this might be a little bit intense for some viewers. So we're showing a video of an actual ear tube insertion. Here we're making an incision in the eardrum, and you can see I am suctioning out that fluid from the middle ear space, which is going to result in an improvement in the hearing right away. And here we're putting a tube into the middle ear in order to maintain ventilation of the middle ear space and prevent that fluid from reaccumulating. Tube insertion is a very common procedure for children with hearing loss due to middle ear fluid. Here we go on the other side. Again, we're making an incision in the eardrum, and we're going to suction some fluid out of that middle ear. But this procedure does involve making an incision in the eardrum, and a question that comes up commonly is, should we perform ear tube insertion in children with Myrie syndrome, especially when we know that children with Myrie syndrome do have a risk of fibrosis, particularly when there's an injury or irritation in any specific area. So here we've completed removing the fluid from the middle ear space. We're bringing in the tube, and we're going to place that tube right into the middle ear with this little instrument. And now this child has tubes. So should kids with Myrie syndrome have ear tubes inserted? There are pros and cons. Some of the pros: ear infections are uncomfortable. Middle ear fluid itself can cause conductive hearing loss and is a common cause of hearing loss. And hearing loss can result in speech delay. And some children with Myrie syndrome are at increased risk of speech delay. So these are things that we want to address. On the con side, there is a risk of anesthesia in children with Myrie syndrome, and specifically that relates to intubation. Now, often we can do ear tube insertion without any instrumentation of the airway. We can use just a mask for the anesthetic, and so there's no irritation or stimulation of the airway. So that can be avoided in most cases of tube insertion. What about risk of scarring of the ear? The eardrum itself is made of skin and a mucous membrane, and there's a potential for risk of scarring. So that's something that should be considered. I personally have not seen a case of significant fibrosis of the middle ear resulting from ear tube insertion in children with Myrie syndrome, and I've seen several children with Myrie syndrome who have gotten tubes successfully, but it's something that we should consider. So my recommendation would be, in general, have a higher threshold for tube insertion. So don't go putting in tubes if you've only had 2 or 3 ear infections, or if there's a period of middle ear fluid only lasting a couple of months. Maybe wait a little bit longer before going ahead with tube insertion. And the other thing is to proceed with a team that's experienced, that knows about Myrie syndrome, and that will put thought into making sure that we take steps to limit the anesthetic time and to reduce instrumentation of the airway. This is also a case where you would want the tube insertion to be done by an experienced surgeon so we can minimize the risk of injury or trauma to the ear canal and tympanic membrane. Now, we can't always attribute conductive hearing loss to middle ear fluid. It is one of the most common causes of middle ear fluid, of conductive hearing loss, middle ear fluid. But there are many other causes of conductive hearing loss, and sometimes children with syndromes, including Myrie syndrome, can have structural abnormalities of the middle ear that can result in conductive hearing loss. And so when there is conductive hearing loss in Myrie syndrome and the ear exam is normal, let's not go rushing to put tubes in the ears. Let's get imaging of the middle ear so that we can determine whether there are any structural abnormalities contributing to this. And typically, a CT scan of the temporal bones can be done without the need for an IV, without the need for contrast, and without the need for sedation. So this can actually be done very quickly. The test only takes less than a minute to do, and we can get good information with this. So let's talk a bit about sensory neural hearing loss. This is that second kind of hearing loss that we talked about, where it's the inner ear that's affected and not the middle or outer ear. So sensory hearing loss occurs within the cochlea. This is a little diagram of the cochlea. That's the spiral-shaped organ that's responsible for turning the vibrational signal, the mechanical signal of sound, into a nerve signal that goes to the brain. And the cochlea is lined with thousands of tiny hair cells. These are the ends of the hair cells that are floating in this fluid. These 3 rows are called the outer hair cells, and this is a row of inner hair cells. And these little endings get moved back and forth when there are vibrations in the fluid of the cochlea that results in a stimulation of the underlying nerve cell, and that sends a signal to the brain. Now, in sensory neural hearing loss, there's often been injury to these hair cells, and here's an example of a cochlea where the hair cells have been destroyed by one mechanism or another, and you can just see a little tuft of one inner hair cell sitting there. So in Myrie syndrome, most hearing loss is actually conductive. 78% of patients with Myrie syndrome do have some type of hearing loss, but it's primarily conductive. Only about 12% of cases are purely sensory neural. And in some cases, this can be slowly progressive, meaning it gradually gets worse. So how do we manage hearing loss? Well, for any child with hearing loss, we want to treat it as soon as possible, meaning early detection, treatment of correctable hearing loss with ear tubes or treatment of ear infections, management of middle ear disease, and then a speech evaluation as early as possible. For children less than 3 years of age, early intervention services, additional local services as appropriate for children with hearing loss. And it's important to repeat hearing testing in children where hearing loss has been identified. I usually get hearing tests every 6 months until about 3rd grade, and then annual hearing tests thereafter if it's been stable. And then if there are any changes in the perceived hearing, to repeat the hearing test as soon as possible. I also recommend annual hearing tests for children with Myrie syndrome, even if the hearing has been shown to be normal, so that we can pick up any change in hearing should it occur. Other accommodations for children with hearing loss would include classroom accommodations, including a classroom evaluation and management of the acoustic environment, uses of strategies like an FM system, and making sure that these strategies are written down somewhere, either in an IEP or in a 504 plan. I also always recommend for children with hearing loss to protect residual hearing. So in noisy environments, we want to wear either earplugs or earmuffs to protect from loud ambient noise, and also protecting from personal listening devices. iOS lets you set volume limits. If you go into music, you can set a limit on your personal listening device and prevent the ears getting blasted from too much loud noise. Other options for managing hearing loss include hearing aids, which have made significant advances over the years. These can now Bluetooth to your phone, and you can stream audio media to your hearing aids, or even talk on the phone while wearing your hearing aids. We mentioned earlier bone conduction devices. These are optimal for children with conductive hearing loss that is not well managed with hearing aids, or if the ear canal is very narrow and gets blocked frequently or results in chronic drainage from the ears. You can get very good hearing results with bone conduction hearing devices that send vibrational signals directly to the inner ear. And finally, for severe to profound hearing loss, we have the technology of cochlear implantation. This is for cases where hearing aids or bone conduction devices are not powerful enough to get a good hearing result, and these can stimulate the cochlear nerve directly, bypassing the entire cochlea with a hair cell system. So now let's talk a bit about airway stenosis. So what is airway stenosis? Stenosis means narrowing, and airway stenosis is narrowing of the airway, which can occur at any level. This is a picture of a normal larynx. These are the vocal cords, and this is the windpipe below the vocal cords. And when we swallow or talk, the vocal cords come together. When swallowing, it's to protect the airway. When talking, it's to allow vibrations to occur across the vocal cord surface. But when we breathe, the vocal cords open wide so we can get a big breath of air through those vocal cords and down into the windpipe. Now, in someone with subglottic stenosis, the subglottis is the area below the vocal cords. You can see there is scar in this area, resulting in a very narrow area of the voice box right here. And that results in noisy breathing, difficulty breathing, and some of the symptoms we might hear in someone with an airway stenosis would be stridor, which is a very high-pitched inspiratory noise, or sometimes even expiratory, meaning inspiratory meaning when breathing in, expiratory meaning when breathing out. And we can have a recurrent croupy cough, or croup. Croup is a viral illness which typically children get once, maybe twice. But if there's a child who gets croup every time, they get a cold or upper respiratory infection, we have to be concerned that there might be a narrowing of the airway that's contributing to that. So recurrent croup is a red flag for airway stenosis. Exercise intolerance, meaning getting out of breath really easy with exercising. That's a sign of a narrow airway. And obstruction during sleep or obstructive sleep apnea. Any level of airway obstruction can result in obstructive sleep apnea, and certainly airway stenosis is no exception. And also chronic nasal obstruction, such as a chronic runny nose or chronic mouth breathing. This can be due to enlargement of the adenoids, nasal congestion due to allergies, but can also be due to scar within the nose. So in children with Myrie syndrome, airway stenosis can occur. Laryngotracheal stenosis, meaning of the voice box or the windpipe, has been noted to occur in up to 15% of cases. And this typically occurs as an acquired, meaning something that wasn't there at the time of birth, but something that is acquired later in life, either due to irritation or just gradual stenosis over time. And this can be highly variable in the severity or degree of stenosis. In one review, which looked at 4 cases, over 33 years, it was noted that all patients with airway laryngotracheal stenosis had prior endotracheal intubation. One patient who had nasotracheal intubation, meaning the breathing tube is inserted through the nose down into the airway, developed choanal stenosis, an example of which can be seen here. This is one side of the nasal cavity, which is wide open, and the other side, which is narrowed by scar. And in 2 patients in this case series, there was the need for tracheostomy. So how do we manage airway stenosis? One is with observation. If it's mild, we can just keep an eye on it. Medical management with control of acid reflux and respiratory treatments during colds. And then there's surgical treatment, which can be done with a balloon dilation or laser incision of the stenosis, or in severe cases, laryngotracheal reconstruction, where a portion of the trachea is widened by placing a cartilage graft into that location. But in general, airway stenosis is much easier to prevent than to fix. And therefore, we recommend that in children who are having a surgical procedure, thought is made behind how the airway is going to be managed. If possible, endotracheal intubation should be avoided. Some cases can be done simply with a mask over the airway, or with a device called a laryngeal mask airway, where the airway device is placed above the voice box as opposed to through the vocal cords and into the windpipe. And of course, if local anesthesia is possible, that's optimal, where there's no manipulation of the airway whatsoever. But if intubation is necessary for a more complex surgery, it's important to use the smallest tube that's possible. To be very careful about the cuff pressure. In an endotracheal tube, there's a little balloon at the end called the cuff, which we inflate in order to get a good seal with the airway. That pressure should be kept to a minimum, and certainly to less than 15 centimeters of water. It is possible to measure cuff pressures, and if long-term cuff usage is needed, this should be done during the case to make sure that that cuff pressure doesn't get high. And one time when cuff pressure could change would be if during a long surgery, if there's a change in the anesthesia team, it's important that every team member who's taking care of the patient is made aware of the diagnosis of Myrie syndrome and the critical importance of maintaining a minimum of pressure against the trachea during surgery. So when the anesthesia team trades, if someone comes in for a break, it's important that that information be communicated as well. So in summary, hearing loss and airway stenosis are very common problems in Myrie syndrome. They are manageable, preventable, and treatable. It's important to have excellent communication in advance, both when discussing interventions, before the planned surgery, and on the day of surgery. And involving a multidisciplinary team can help improve care by optimizing this sort of communication. So now I will take some questions which have been sent in advance from the potential audience. The first question is, can Losartan be used to reduce fibrosis in the ENT area? This question is likely based on some research which has been done looking at Losartan and its effect both in vitro in lab studies on cultured cells from patients with Myrie syndrome, as well as this pilot clinical trial which looked at 4 patients with Myrie syndrome who were started on Losartan for a period of up to a year, and in which there was some improvement in skin thickness, joint stiffness, and to some degree, but a lesser degree, in myocardial strain. This was a very small study with only a few patients, And there was no data reported in this study on either airway stenosis or middle ear disease. So I think this is one where we'll have to sort of look very carefully in the future and see how this comes out. It's certainly very interesting and I think important to follow, but certainly larger scale studies are going to be necessary, and longer term studies are going to be necessary to answer this question as it relates to airway disease. The next question would be any more developments regarding ear tubes? And I'd have to say, I haven't seen any new studies about this, but I think it's important to continue to weigh the risks and benefits. And if there is any question of whether tube insertion is necessary, I would say in borderline cases, maybe wait and see a little longer. Sometimes middle ear disease does resolve spontaneously with a little extra time. So I think the best answer here is to just be thoughtful about tube insertion and not rushing into it. And the last question is, how does hearing loss progress over time? And I would say for this question, I'm still not sure. I think that there are certainly cases where we've seen gradual progression over time, but for any one patient, it's very hard to answer this question. I did mention the importance of annual testing to look for progressive hearing loss, but another reason to have annual testing is so we can learn more. As we have more patients with annual testing, we can study this disease. And there's some good long-term studies with diseases, for example, Stickler syndrome, where with long-term outcomes from annual audiograms, we've been able to see a gradual progression in the average patient with this condition. And I think this is something that we will certainly be carefully studying as time goes on. So I would like to just put a plug in for the multidisciplinary care, which we do offer at Mass Eye and Ear, both in our pediatric hearing loss clinic and pediatric aerodigestive center. And we're always happy to help by seeing patients for consultations and answering any questions that people might have. And with that, I'd like to say thank you very much. This is my contact information. If anyone would like to send me emails directly, please feel free to do so. My office number is here as well, but certainly email is a very convenient way to reach me. Thank you very much for your attention, and I wish everyone a wonderful day.